That's remarkable. Bruce has never been on time. It must be the paddles. Our next presentation is going to be from Ed Delaney. I suspect he needs absolutely no introduction to people in this audience. Ed's the Assistant Professor of Cardiovascular Sciences and Perfusion Medicine at Hofstra University and the Director of the Perfusion School. But I think where he served the community is where he's best known for his extensive period on the American board and on the New York State board. So with no further ado, he's going to talk to us about the Perfusion Program and Program Directors Council. Thanks, Ed.
Thank you. So, that's loud. So Deb Adams and I put together a few slides. The Perfusion Program Directors Council met yesterday. It's probably a lesser known group in perfusion. Obviously, Deb's from Texas Hard, I'm from Hofstra. But a couple of slides that'll kind of set the base, I think, for our panel, if you will, on numbers and what we kind of do on the Perfusion Program Directors Council and how we liaison with the Accreditation Committee for Perfusion Education. So there'll be a lot of acronyms that I may spit out in the next couple slides and as we go through the panel of experts. So just going to talk a little about the structure and role of the PPDC, number of accredited programs, some general updates, and just talk about what both groups are doing when it comes to standards and guidelines and consensus curriculum. So the Program Directors Council, they get one director that represents each school. That group meets about 3 or 4 times a year. And then we discuss organizational and institutional feedback and potential solutions issues that are going on within the perfusion community. We liaison with the Accreditation Committee for Perfusion Education. We liaison with the American Board of Cardiovascular Perfusion. We liaison with the national societies, local societies, state societies, and then we actively participate in the work done on the ACPE. And then we record our current programmatic numbers and we compare them to the attrition rates. And that information, if you don't know, could be found on the Perfusion Program Director's website and also on the American Board website. And I kind of just alluded to this a little bit, but that's our website. We do have a website that kind of has all our statistics on it and the number of programs. And essentially what we're going to do is we're essentially liaisoning with these groups to kind of foster competence in perfusion graduates and exchange information essentially. These are the number of perfusion schools that have been accredited in the U.S., and you can see how it's changed over the last 7 years. We currently have 22 programs, 1 in candidacy, 6 are certificate level, and 16 are master's level. So you have seen that kind of progression to a master's level. And then I know a number of the programs that are certificate have either considered going to a master's level or partnered with a university in some way. Once again, 22 KHAP accredited programs. In 2023, we put out 239 graduates. 24 was 289 graduates, and 25 was 311 students in the program. And that one of the things that council does when we meet is we kind of talk about numbers and what the needs of the perfusion community could be, and how far to flex putting more students in programs, or even if we have the ability to retract once we put a number on our individual programs, whether we can flex that back and forth. That slide's a little small. It's probably bigger up there for you. But they're the schools. They're the number of the graduated 2023, the anticipated growth, and the admissions for 2024. And what we did yesterday is we retook those numbers. And over the next 2 weeks, Deb and myself and the group, what we'll do is we'll make sure we have accurate numbers for each school. We had a couple of schools that didn't participate just because of timing issues with graduation yesterday. Yeah, if anybody wants to take a picture of that slide, I have another slide that includes the other schools that are on that I couldn't fit on that slide. And there's the other 2 schools. They're the 3 of the newer schools within the last couple of years. So I took this slide with permission from the ACP, and what they're working on this year essentially was the standards and guidelines. So every 5 to 7 years, we revise our standards and guidelines. And part of that is the consensus curriculum, what we teach off of in the programs. So that's a big kind of, you go back and forth with our accreditor, KHAP, and we make sure we're in alignment with the accreditation. So the schools are aligning with the COA, which is the Committee on Accreditation, which is aligning with KHAP. And then we have a number of committees that we look at for site evaluations, for annual reports on the ACP. We do have a new program report, an annual reporting system. Each program has to annually report a set of metrics to the ACP and KHAP. Couple updates from ACP that they wanted me to talk about was graduate and employer surveys, the responsibility of the programs that distribute this and collect this information and then report it out to the ACP. There's a clinical affiliation form. The only thing you need on that now is CV, but you do need to have all of your preceptors' American board numbers currently. And then clinical affiliate modules have been suspended. And they're working on something new for some preceptor education. What we did on the Program Directors Council this year is we worked on the consensus curriculum in conjunction with the ACP. So that's some of that work. And you can find that on the standards and guidelines on the website under Appendix B. And then what our overall goal is to put that consensus curriculum in the standards and guidelines. And within the standards and guidelines are in the process right now. The revision is, they're going to KHAP. So we sent one revision to KHAP. They sent it back with comment, and then we're further revising that. And that should be hopefully done by the fall. And I talked about a little bit of that. We'll skip that one. And then just to kind of get our talk going for the panel of experts, you know, one of the things we're always looking at on these committees is resources. So capital resources versus human resources, essentially qualified educators. A lot of times in these committees and groups, you see the same people kind of going with the same groups once they get an experience level. So them dual roles, there's only a certain number of us. There's field limitations. There's information and technology that's grown tenfold over the last few years, and it's how to kind of integrate that into your programs and keep up on everything that's currently going on. Then there's always been kind of a debate about the appropriateness of the degree in the programs that we always go back and forth about. And then it's how to kind of incorporate AI and newer technologies into the program. So kind of like a risk-reward type thing. And then the one thing that a lot of us that are educators are always talking about is the evolution of kind of the learner these days, and how they learn, what areas to go into where they may learn better, how to pick an applicant, what will make a good perfusion applicant. And Bruce kind of alluded to a lot of these different technologies I think that you're going to see being used forward. You know, and like the progress simulation, VR technology that's being used, how accessible the information is. I teach a class and I can have students literally fact check me in the room like while I'm teaching. Or even if I stumble in a lecture, I literally can have somebody correct me based on their iPhone in that lecture. So it's definitely a different kind of teaching environment. It's keeping up with it and doing cases and kind of doing all these different committees is definitely challenging. So, and like I said, the information's grown tenfold over the last few years. And I'm not going to take questions now, but I think we're going to do the panel of experts and then we're going to do some questions.
So Bruce, if you'd like to come up, and I'll introduce our other two panelists. We have Deborah Adams, who's the Director and Clinical Coordinator of the School of Perfusion Technology at Texas Heart. And coming to us from Europe, we have Gerdy Debeuckelaere. I hope I've gone close for that pronunciation. He's the General Secretary of the European Board of Cardiovascular Perfusion. and Chief of Perfusion at Antwerp University Hospital in Belgium. So the floor is really open to you guys to take this where you'd like it, but we have some topics. I might ask the panel if they want to start with anything in particular, and then we'll just let it free flow. Or I might start with a directed question. Sorry? All right. Look, I think Bruce's presentation led us to an obvious starting point for this conversation, and that is the role of simulation in education going forward. It really comes into the global question because it's something that we can globalise. You talked a little bit about that. It comes in at both this education level and at the recertification level. So I think perhaps we can start with your opinions on where you see certification as a mandatory component of your education programs, and then the secondary question, simulation for recertification. So we might start with Gerdy.
Yeah, great. For certification, when we look at a simulation in Europe, when we accredit schools with EBCP, we do site visits. And one of the important topics to cover in a perfusion program is simulation. So there is always a quotation on the fact, is there simulation and on what level? Because we see simulation going from very basic to very sophisticated. What we also see in Europe, I don't know if it's the same over here, more and more congresses are really covering big simulation workshops. For example, our Europerfusion Congress that we have in Athens this year. For the third time, we have SimLab sessions with different type of devices used, different type of patient population, and I have to admit it's very successful. And third, what I would like to add as well, in Europe we have a recertification program for each perfusionist. Simulation is one of the things you can score points with to have your recertification each 3 years.
Just to clarify that, it's not a mandatory component of recertification at the moment?
Not so far, no.
Okay.
It's one of the options.
Yeah.
Is that on? Yeah, there we go. So in the US, we also have it as a component of recertification. It is not mandatory, but a number of years ago, there were a group of us that assessed simulation and the potential for it. And obviously working with Bruce and a lot of his counterparts in simulation. And we decided to put that in as a case credit for recertification. And then Program Directors Council, ACP, and the board all decided that for education, it'd be great to integrate into the program. So I think every US program is doing some form of simulation, whether it's a combination of low and high fidelity, whether it's a combination now of high fidelity and virtual, in arenas like Bruce talked about for ECMO bypass. So I think you're going to continue to see more and more of that, and I think you're going to continue to see standards, guidelines, and competency around that as the future goes forward.
Can you hear me? Thank you very much. I'm intrigued by the use of simulation and what Bruce touched on about being able to educate in countries, low and middle income countries that don't have the human resource to teach. That's something that I've been passionate about and Bruce has been passionate about for all of our careers, and to be able to utilize that technology to be able to, because the human resource component to teach the skills is the hardest part, and it's very time and labor intensive. So now that we have technology that we can do that, I think the sky's the limit, and I'm really excited about it. So thank you. And you all get involved, so.
High fidelity. high fidelity simulation is very resource intensive. We put 600 hours into our simulation curriculum, and there's a faculty member there, and we have to reduce the class size. So there's maybe 3 to 6 students in one faculty, whereas in the classroom, you could have 20 or 30 students in the classroom. It sounded too loud. So yeah, it's hugely resource intensive, and that's where you'd want to save the money. If you could get 30% of the job done on a screen and have 20 people here doing that with one faculty member, and then save that 20% when you get to the sim lab, that's a big deal.
Yeah, we just bought the virtual technology. We're going to start applying it, putting in the curriculum come the fall. So yeah. That's one of the things we're definitely doing, but you're right about the labor intensiveness of some of the simulation. In order to do this simulation correctly, you do need pretty much full-time simulator operators. So I've definitely noticed that. So
it would seem that the virtual simulation is the segue into making it an easier component of recertification. Would you think that's a reasonable step in terms of being able to globalise it?
Oh. Yeah, sure. You could certainly demonstrate knowledge, that you understand relationships and you'll make good decisions. It's decision making and knowledge base. It's not necessarily tactile skill. There's a lot of students that can pass the test. Smart does not equal competent. You could test at a very sophisticated level with a screen-based thing that you're smart, but you still could be totally incompetent. It might take you 12 seconds to do something that has to be done in 2. You're incompetent. So you need to ultimately get to the demonstration with your hands, I think, in our particular field. Our field is so perfectly suited to simulation. You think of this and pilots. I know we compare ourselves to pilots so much. I wonder if pilots are honored or if they're disgusted. But we have those professions. Let's go to like nuclear engineering. So they don't let you move the uranium rods until we're sure you're going to be able to do it correctly. And this is what we do is life and death. And what we do is so hands-on that, and it's so specific. We do it in one place all the time. It's the operating room or it's the ICU. So it lends itself to high fidelity simulation, and we can make it really, really, really effective if we build the teaching techniques around it. So you need the educators to take the time to build the scenario and then deliver it over and over and over again, and then write an assessment and then do that to 100 students so you can say, coffee in my office.
Are there enough resources? Are there enough resources available for groups like the Perfusion Program Directors and the European Board to support all of the schools in getting up to an adequate level? It seems to me that, I think Bruce, you highlighted it with the Califia. Orpheus was a bit of plug and play, and it was pretty quick. Califia is, a much more intense, much more deeper involvement in learning how to get the best out of the system. So is there enough resource to support that?
I think we're getting there. I think with the vendor support, I think with educating our institutions, some of the conversations even yesterday we're having at the Program Directors Council is essentially additional fees to implement, to support some of this extra education that's now an expectation of the student, and how you offset that. So each of us have budgets, so we all can do things within the limitations of our budgets. And I don't think everyone is created equal in that regard. So I don't think there's a level playing field right now, but I think eventually we'll probably get there. So
I think one of the things the platform is set for us to collaborate in a way like we never have before. And now most of these schools have a Califia. So if we were to put together a panel of people, and there's probably schools in Europe that have the Califia, and if we were to put together a panel of educators, and we could say, these are the 10 scenarios that every school wants. You can still have your own independence as to how you operate that scenario, but there could be a thumb drive that floats around the entire world, and everybody starts with that common base. And I only have to write one, and you write one, and you write one, and we share them, and all of a sudden, there's a level of commonality across education that has never existed before.
One of the things I talked with some of the simulator companies about is having those pre-built modules that we would all have, those base modules, and try to form some kind of competency essentially. And then obviously have the capability to really kind of have that unique kind of scenario that you're really testing, like for disaster training and different disaster training, or actually going in and saying, hey, this happened in the OR, let's mimic this in a simulation. So
With regard to having the companies provide the educational content, my experience has been they're really good at programming and we're better at education. So I think it's going to take a collaboration. I look at some of that VR and I think, I love this environment, but if you stop for a minute and the shininess of the environment wears off and you're like, okay, now I'm watching somebody wean from bypass. Oh, I'm failing you. You know, that wean was terrible. In one of the VRs, you never see the hemodynamics. You wean entirely by put all of the volume that's in your reservoir into the patient, clamp, wear off bypass. That's how the scenario runs. That's not a good educational tool. That's a great game. So we need to get involved with them and tell them this is exactly what I need for this to be my textbook. Other than that, it's just a game.
But it sounds very much like some of the steps we've had in our development of the heart-lung machines over recent, last 20 years. We've had pump manufacturers who've gone into software and software manufacturers who've gone into pumps. And as they learn how to do both better and better, we get much better systems. So as educators, yes, you need to learn virtual reality, but you don't need to learn to be developers of virtual reality. You need to integrate those resources. So it's very important.
I was saying I see several of those sitting in the audience that have done both of that. I think that the resources are there. We just need to connect the dots and reach out to our international partners so that, because just here in the United States, it seems like we have several hats and we pass it around and we pass it around. And so at some point you get tapped out. And so we need to be more inclusive. Some people are like, well, how do I get involved? And then we need to partner with our international partners that can teach us and we can teach them. And my goal would always be for us to then be able to go and train where there's somebody that there's no one that knows how to do this, so that we can train the trainer.
Good, yeah, Gerdy.
Yeah, I would like to add something from European perspective. I agree, not only simulation is important to collaborate and to share resources, but a trend we see in Europe especially is to share experts in education in general. Some great schools have great experts in a specific domain. We have in other countries experts on another specific domain. And since COVID, everyone knows how to use a computer, how to go into a virtual classroom to get taught by experts from more than 1,000 kilometers away. So I think it's not only in simulation, but we see a lot of exchange of expertise and resources on that level as well.
I think it's one of the gifts that COVID gave us was we learned that historically Teams Zoom meetings were hard work. That made us take them in as part of our everyday life, and now we've come out the other side and we're getting a balance again, but we're all very comfortable with the platforms, and I think they're a much better tool than they used to be. Can we have the microphone down on the floor, please? If we pass it to, that's good. Just introduce yourself as you ask your question, thanks.
Hi, Greg Matty from Boston Children's. I have a couple comments and a question. So first of all, I want to thank the Perfusion Directors Council. You guys are educating 300 perfusionists a year. That's a massive job, and we need our replacements. So thank you very much. You guys don't get thanked enough. And I'd also like to comment that Ed, Deb, and Bruce, I've hired people that you guys have trained, so thank you. My question is for Bruce. In your presentation, simulation, it used to be the future of perfusion education. Now simulation is a major part of perfusion education. And one of your slides, most of your slides had skill-based information, but one of your slides said further along in your training of your students, there's a clinical relationships component, or at least that's what it said on the slide. And I'm interested in that because what we have found at Boston Children's is that we have used high fidelity simulation. We have a sim center and whatnot. We have not used it in the cardiac operating room for skills-based training. We've used it for team-based communication training. And so I was fascinated to see that mentioned on your slide. And I was just wondering if you could comment on that, because if there's one thing that students sometimes lack is that confidence, or to have that confidence in professional relationships. So could you comment on how you integrate that in your practice?
Yeah, sure.
That's
so we definitely look for all three. We're trying to build all three learning domains into our simulations. So your psychomotor, your cognitive, and your affective. And underscoring again the previous point of perfusion was built for simulation. 80% of your communication during a case could become very protocolized. We have a script that we introduced by like week 5 that is a conversation. And we're going to teach you cardiopulmonary bypass in a minute here, but first, this is how it's going to roll out. And it's a conversation between you and the surgeon. He's going to ask you, are you ready to go on bypass? And you're going to say this. Before you say yes or no, you're going to evaluate these 5 things. Right now, I want you to speak all 5 things out loud. Hard code it. I want it to come out of your brain, out your mouth, back in your ear again. I want this to happen hundreds of times. When you get to the operating room, shut up. Just say yes. And now if you go to the operating room and train, that's all you hear is a perfusionist say yes. And they say every day the perfusionist can say yes. And you're not going to know why they said yes. You're just going to learn to say yes. But they evaluated 5 or 6 things. So affective domain, we teach them to talk. We teach them to evaluate things. We teach them to talk. We give them suggestions. It's like it has to be clear, concise, correct, and confident. And it also, you only get 2 sentences. Those 2 sentences, first sentence, tell them what the problem is. And if they don't solve it right away, which often they will, give them a second sentence. This is my solution. This is my suggestion. That gets you 80% of your conversations. If you're capable of having that much conversation, you probably are going to more easily develop the next level of, hey, we're off the chart. There's something happening. I don't really understand it, and I need to dialogue with you about that. You're not going to go, oh, doctor, I'm having a problem back here. I'm not exactly sure how to explain it to you, but I'm going to have to talk to somebody about it. 3 sentences in, you haven't described the problem yet. So we're still working on the off the map communication, even when we're just teaching you to follow a script.
So we do a bioskills lab, cadaver lab, and we have cardiac surgeons, anesthesiologists, and perfusionists all training at the same time. And it's where we kind of really focus on closed loop communication. So we don't really use the high fidelity simulator as much. And that kind of goes on basically when we can get cadavers and when we get the cardiac surgeon that's our medical director to do it. But that's one of the things we've done in the past for closed loop communication.
I think that's what you're talking about in terms of learning how to talk. And it's, if you look at, again, go back to the airline idea, is that when you communicate with air traffic control, there is a set way that you talk, terms you use, the kind of order in which you go through, which the idea being is that it doesn't matter what pilot from what airline and what air traffic controller you've got, you have a standard way of communicating, so it doesn't matter who's there. And I think there is an element of that's kind of necessary in the in an operating theatre, because you need to be able to communicate in the same ways. It's like the call and repeat an idea. Bypass off. You repeat back what so you know you've heard it or whatever it might be. But you still have to have. There's a fine balance between having that sort of almost too protocolized and then not being able to talk about anything else. But we need to almost come up with this sort of standardized way of saying, actually, when you communicate, these are the things you have to do, like a bit like you're saying, without handcuffing people too much to do this.
It's quite interesting with the airline analogy, just Bruce, just quickly. We get so drawn into this relationship with the airline industry. On one of my many flights to get here, the people in front of me, you get off an aeroplane, you walk up the passage and you turn left. They walked up and went straight into the cockpit. I had never seen that. Back in the day, I remember a 747 coming to an AMSET meeting, being in the cockpit. Things were a bit different back in the early 90s, but it would just blew me away. Straight into the cockpit. Sorry, Bruce.
To provide some standardized communication in our curriculum, and maybe it would be a good national research project to talk about what is the standard elements of communication, try and take what is curriculum and determine whether or not it's standard of care or if it's just our special way of doing it.
And I think this, so going on from that, this is kind of the ideal sort of panel, or at least the platform release, to then start that conversation is, go an international thing of what are the fundamentals that we need to have no matter where we are in the world. And it can, the same as we're talking about, what's the best way to educate people, what's the best way to simulate, we need to have that, sort of baseline to which to work. There's something like this panel could actually sort of be at the start to say, actually, let's even think about it from a very basic point of view of how do we communicate in the operating theatre, and have that as a sort of something that we then all agree on and go forward, because that will also help, train other people from all over the world, which is just, and again, it's that way that everybody, no matter where they are in the world, will be able to have the same conversations in the same way, based upon sort of the best kind of data.
George Justice in Denver. It seems to me that one of the biggest demands for simulation is non-perfusionist education, at least in the clinical setting, ECMO specialists, physicians, etc. And there's a steep learning curve, not only for using the various simulators, but most of us clinicians are not professional educators either. And I think a product that would be marketable for all of the programs directors is some sort of postgraduate certification in simulation education, whether it's done as a capstone project or more specifically a postgraduate certification, I think would be something very valuable for you all to offer to the community to help not only increase the proficiency of simulation education in the clinical setting, but also the rapidity at which it can be deployed.
And one more question from the, sorry, Bruce, were you going to respond to that?
I was just going to say, email me. Yeah, let's do it. Yeah, I've offered that to other people that they wanted to learn how to do simulation. They have some access, and now they're like, I wish I paid more attention when I was in class. So yeah, I'd be happy to have you back and spend some time online, give you some things to read, and let you come and practice with our students. Totally let you do that. Free labor, absolutely.
Any other comments from the panel?
I was going to say it takes time, definitely repetition in that. Seeking out that, it's been difficult over the years, even when all of us have kind of learned. I don't know what your initial experience was, but to find somebody who could teach that and be there repetitively. So seeking out that knowledge and that education has been difficult to get because there's limited resources to get it. You have the companies, and then beyond the companies, it's each other, essentially.
You're saying 17 years of progress here. 17 years ago, we put an Orpheus on a table and moved the table, the actual classroom tables out, and said, this is a sim lab now. And it's been quite a wild ride, but there was no instruction. And I feel fortunate that I didn't go to simulator school, because they teach you a very certain thing that I now I'm glad that I know about it, but I don't want to teach it that way. There's the whole, we got to have a pre-briefing of a certain period of time. You're going to have a 15-minute vignette, and then you're going to have a 45-minute post-briefing. We're probably going to cry at the end of it, and there's going to be a lot of hugging. And then I got no time for that. We're going to put it on video. The students are going to watch it later. A lot of learning is going to happen in a really short period of time. So that's full mission simulation versus vignette simulation. And I understand why they do vignettes, but we're full mission.
Question up the back.
Hi, so I'm from the UK. I'm a British student. So our education system is drastically different from the American system. So we don't have the privilege of having simulation. However, we also have the privilege of actually working with patients within the first month. So I was wondering, with simulation, you've got the use of AI, and obviously that brings its own challenges and also its own benefits. So with that, obviously using AI, there's a level of complacency that's developed within students, and hence why I think that during simulation, well, do you think necessarily at the start of education, would it be possibly more beneficial not to use it, and therefore be able to be more independent when AI comes? Because I think with my upcoming generation of new perfusionists, maybe we're going to become more reliant on, for example, server regulation from level detectors, and I think it's really interesting. So yeah.
So I think as we integrate these new technologies, I think you have to be a little bit cautious, especially when you're doing training a certain way, and you have a different type of learner, like I spoke about earlier. So I did have students using AI to take notes. And so they were taking notes off of everything I said. So the AI was generating everything I said into note cards for them. So they took a 2-hour lecture, and then they went back and studied everything I said in that 2-hour lecture and didn't really focus on the key points I was making. And what they were essentially doing is they weren't maximizing what they were supposed to study and weren't maximizing their time. And we saw last year for the first time a number of students do poor in a class that all the students kind of knocked out of the ballpark year after year. And what that class was doing was making these AI generated notes. And it's a technology that I wasn't as familiar with, and I'm definitely a little more familiar with it now, because I really think it affected that student population for that class. And so temporarily, I've asked them not to use AI to take notes. I want them to be present and listen and make sure that they're focusing on what I want them to learn, and not necessarily like if I go down a rabbit hole and tell a story based on what we're teaching that day, I don't want them to focus on that story. Like I want them to focus on the things that they need to know that they have to reproduce. You know, there might be a point to my story, but that's not the education that I wanted them to focus on, essentially. And not that I tell a lot of stories, but
I think, and I've had a student use that, but the story part, and that's a story about an experience and trying to tie it back to whatever we're talking about. And my students are in the room and they say, Miss Deb's tests are, they're like 3/4 of her random tangents somewhere over there. And the AI doesn't tell my story right. So I think, you know, lots to learn with that. Your way of learning is the THI way, or the has been, and so simulation, high fidelity simulation for us is new. We've trained 50 years with a bucket of water, and so this is, you know, I'm in my infancy trying to learn about simulation too, but I think that there's a place for it, absolutely, in all parts of learning. And because it's so labor intensive, we're going to tend to use it at the end of training for more crisis management and continue to teach our students the way we do. So communication, for example, is learned in room 2 with a physician that can teach you how to communicate very quickly. And I won't name his name, but he's a famous surgeon.
Richard?
Yeah, I was going to just sort of carry on from that comment in terms of AI is a really interesting thing in terms of there was a sort of fairly famous, if you're interested in this thing, where they got GPT and said, here's a photograph, reproduce it exactly as it is. And they run that query 70 times. It was just of a girl's face. And by the time it finished, it was just completely unrecognizable, to the point that it managed to change race. It moved that far from where it actually started. So there's a lot of problems in terms of it's not perfect. So choosing where to have that is the main thing. And I suppose going back to the idea of, how we train people in the UK, you go straight into practice, should we say, on real people very early on. That's really down to the realism that you're trying to impart on that. So as these simulations improve, there should be really a way that actually it will take over because it becomes so realistic. And I think this is where, like the manufacturers, for example, can help out. And sort of big data, Gerdy and I have many conversations about this. If we could create essentially simulated patient data or a patient journey today through the entire operating theatre based on real data, so we know that if you give this amount of drug, it will raise the pressure by X. If we can start imparting that into the simulations and it becomes ultra realistic, then you can move away and understand this thing. And I think the further point, which is what I'm going to try and get to in terms of asking you, is if we then are talking about recertification, so in the UK, for example, you have to do a certain number of cases. What about using it to do the emergency changes out? That is where realistically everybody should be focusing on the efforts, because going on and off bypass multiple times, we probably all do it with their eyes closed. But what happens when you have the pump root rupture, the oxygenator change out, all these other bits and pieces, which where is really a perfusionist earns their money by bailing everybody out of the. Okay. That's where we need to sort of really practice and perhaps look more at the certification or recertification of. And maybe that's where AI and machine learning and stuff could actually come in useful.
I mean, I agree with you. I think a lot of that depends on access and resources when it comes to getting everybody in front of a simulator, because there's a learning curve using a simulator. There's a nervous system using a simulator. You can go on bypass in a case every day, and then all of a sudden go into simulator and everything doesn't work out well. So I definitely agree. I think it'd be really neat to use for recertification, especially in disaster training. So like Deb said, how she's going to incorporate simulation for disaster training. That's how we use it in my school right now. What we do is we go very heavy on low fidelity, essentially almost with a dummy and pretty much a bucket technique. And then we get students out into clinical very early, and then we bring them back and do high fidelity with disaster training. And there's a couple other things that we kind of integrate in there. And then the newest one's going to be the VR in the fall. And we're going to set that up into a class. And everybody's going to get the technology, and then that class is going to kind of learn it with me and the other director together, and then we're going to use it moving forward with the VR, try to figure out what the positives and negatives are and where the bugs are essentially. Deb wants me to videotape myself, so yeah.
Tristan?
Oh, yes, Tristan from Stanford. You four have my dream job. I would love to be able to educate. And of course, Deb is one of my early mentors, and I appreciate all that you do. But I wanted to piggyback off of something that George said, which is about our preceptors. So once you give your students over to the community to learn, what about a checklist for those preceptors? I know at Stanford, we've undergone some changes in our education. We have a wonderful, one of our former students who's hired on now, who really took our education and makes the students feel comfortable, has checklists for them, has it really dialed in. Is there any ability for you guys to help the community with that as well?
It's probably easier for us as directors individually to help our preceptors in a group. We've tried some things nationally, like we did have some preceptor education on the ACP website. I don't think it really hit the goal. And I think, I think when it comes to those resources, I think we're going to try to do it again. We've talked in the Program Directors Council about it a little bit. We've talked on the ACP level about reinvigorating that. I think each of us has our own way to kind of instruct preceptors, and we have tried to put a little more teeth into that, but it's a huge area where we definitely need education and some kind of consistency or rubrics to use in that area. Yeah, I think it's something that we could definitely, as educators, look at.
We've got some online questions.
Okay, this is a question from the audience, the virtual audience. What is the percentage of new grads that have left the clinical environment within 5 years of graduation? Any information on what might be the factors that create these early exits?
I don't have any hard statistics on that. I could probably anecdotally tell you why people leave. Do you have hard statistics on it? Oh, it's like, yeah, I think anecdotally why people leave perfusion is they may get into it and realize it's not for them over a course of time. I think maybe quality of life, I think burnout, I think stress plays a role in that, what we've seen. What else?
And what I've seen people want 0 to 5 years is transitioning into clinical sales or something on the manufacturing end because it fits more into, say, quality of life or work-life balance. But that's a good question. I don't know statistically.
I agree. We don't have any statistics on that. So we're anecdotally thinking about our classes right now, and very few.
Do you have the numbers on how many are leaving the profession each year? If you're training a bit over 300, is that close to a balance now?
I think this is it's kind of a loaded question. It's hard. It's always a moving kind of dot. I think we're getting close to sufficiently supplying the perfusionists, but then as those perfusionists go and they go into teaching and they go into simulation, they go into further ECMO training and different things, I think that's going to move, and it has moved, and because we were putting out more perfusionists now. We have more perfusion schools now, and we see people staying in the field a lot longer. And the other thing is, the question was about transitioning out of the field. What you actually see is perfusionists will leave the field, go into sales, then come back to perfusion because they're missing that, essentially what they love. You know, they think, okay, I want a better quality of life. Let me go into sales, or let me go into teaching, or let me go into different things, and they end up back in perfusion, most of them. And teaching is not a better quality of life, I don't think. I think it's an extra layer of stress, and I don't think it ever ends. I think you have to, if you want to start a program, you want to teach, I think you have to really want to teach and love to teach. And I think that has kind of its pluses and minuses when you're doing it, as we've all probably seen. But I would consider, instead of starting a new school, to be in a clinical site for an existing school, and this way we're not dividing resources. I think if there's an area where there's not a school, then obviously it would be a good thing, but I think we need to kind of utilize our resources. And when I say that, it's the number of people who are experts that'll teach this stuff, the number of people that'll stay in the field and be directors and still be competent and do cases and kind of. Yeah.
Gerdy?
It's probably another remark. When we look at the 2024 guidelines on adult CPB, we have a chapter on education of perfusionists, and simulation is one part, one recommendation. All recommendations are expert consensus due to lack of evidence. There's only one, and that's simulation. There was evidence available. Backside of the medal is that it was a class 2A recommendation and not class 1 recommendation. So I think we just need more scientific research on this topic as well. Simulation, your research was a light point. Frank Merkel in Germany is doing great research as well. So I think the take-home message would be, please do some research on the topic to have more strong recommendations.
Okay, we might just change direction a little bit. One of the topics that this group should address relates to globalisation of perfusion and perfusion qualification. And how do you see the program directors, the European board, boards like our own Australasian board, working together to get a global standard that is fully transferable, and what are the barriers to that? So maybe, I know, Gerdy, you've been talking a lot in this space, if you'd like to start us off.
I think it's already mentioned. I think the most important limitation is resources. And then we need to share potential resources that are available.
Yeah, I guess I'd just push you a little bit harder. You know, as an Australian qualified CCP, I couldn't work in America, for example. Is there a globalisation of perfusion qualification that could break down some of those barriers?
We are very into collaboration on that level. It's not so easy because there are a lot of difference between, for example, the American situation and the European. In Europe, we don't speak one language. It's very difficult to overcome when you educate people. And there's no legal background in Europe as well. So we are moving forward. I think, honestly, we are improving. But at a certain point, we need to collaborate more because in Europe, there are great experts in the field. The same in America, the same in Australia and New Zealand. So we are demanding partners to collaborate more.
The one thing I've learned over the years, especially as you go to other countries and speak with perfusionists from other countries, is the problems in the US are not the problems of the other countries. And I think having an understanding of what your resource limitations are compared to our resource limitations, it's very different. A number of years ago, I got to go down to the Latin American Association of Perfusionists, and the conversations all circled around getting actual disposables, getting resources. There was political implications in getting those resources, and there are not a lot of the problems that the US has. We have different structures in education. We have different layers. Like our perfusion groups are not the same as your perfusion groups where it comes to certification, accreditation, and even how we teach. Some of those groups are all intertwined in other countries. Some of them don't exist in other countries, and some of them are in development. So there's the one thing that I believe it was AMSEC that put it together a number of years ago. There was a liaison panel. I was on it. There was people from Germany and different countries, and we were actually talking about resources and sharing information. And unfortunately, that had fallen apart over a number of years. But initially, it was a really, really interesting, unique group of individuals that were just trying to learn from each other. And it's something that we should probably invigorate again.
So, Rob, I would say embedded in your question was the answer to the question. In that you said, why don't we have a collaborative clinical credential that works anywhere in the world? And how can these organizations help it? Those organizations stop it. I think immigration is the issue. Put it right out there. I have talked with other countries, like, how can I train people for you? And they've come out and said, I don't want you to train other people because then they'll stay here. So maybe we're just the wrong group to be offering it, or we need to change the target a little bit. I think a credential that allows anybody to work anywhere is a long way away because of the immigration issue. At every border, they'll shut it down in both directions. That's been my experience. But the globalization of an educational process, I think there's no reason, there should be no impediment to that, as long as we're very clear, we're trying to elevate education, I'm not trying to steal your employee.
Okay, we've got about 3 or 4 minutes left. So if anyone has a burning question for the panel, we have one here. Can we have a microphone, please? We've got 2 minutes now, but we'll get the microphone.
Thank you. So I don't know, maybe I'll get lucky, I'll get the last word. Mark Pearson, and I just wanted to say that, I've had the privilege now for about the last 30 years to be a clinical instructor for many of the programs represented here and not represented here. And I know that you all view it as such a privilege to work with these students, and I would like to say that so do we. I know we have a lot of students. Who's here today that's a student? So I don't know most of them, but what I know one of them. What I know, based on 30 years of experience and seeing what the applicants look like today, is all those people whose hands were up are all brilliant. Because you're not getting into school today unless you're a very, very high quality applicant. I'm really glad I'm not applying to school today. There's no way I'd get in. But And they all have the love of the patient, and I think that's key to the whole thing. So just before we left, I just wanted to say thank you to you guys, and thank you to all the students. And we want you to know that it is our privilege to participate in your education.
Yeah, thank you for saying that. And we appreciate our clinical instructors. And I think that, we didn't really touch on challenges, but clinical instructors, hats off to you, because there's no programs, there's no training, there's no school without our clinical instructors. And I ditto to what Bruce says. I think we need to stop being afraid of what we don't know and learn more about each other and reach out and share education. Our responsibility as educators, and we're professionals, is to pass that knowledge on. And there's such a need for knowledge to be shared. And we need to be passionate about that and do that every day, whether it's in this room or across the world or wherever we might be. So I appreciate you all being here. Thank you.
We've got one quick online question, and we've got one.
How many programs are currently running in Europe these days?
Programs are currently yellow.
I don't have the real hard statistics. I think it's about 20, but I'm not part of accreditation committee director. So, but I wanted to add one more comment. I think we are all lifelong students, so I raise my hand as well.
I think with that, we might thank our panelists for what's been a fantastic session, and clearly we could go on for a lot longer. So take your questions out to coffee and this evening's party. Cheers.